Hello, good afternoon.
Yes, Dr. Kim,
Welcome
you're
to-
live.
Yeah, welcome to SNU Hospital. I'm H.S. Kim. My co-operators are Dr. Gubon Guan, Yang Amo, Han Jung-gyu, all faculties in our hospital, and the anesthesiologist, Professor Kim Tae-kyung, and my fellow to see the ECHO, and many staffs. Let me introduce my case. Slide, please. Plus, 77-year-old female patient had breast cancer in 1986 and received curative mastectomy, chemotherapy, and radiotherapy. In 2011, she had esophageal cancer and received BATS-assisted EVOLUT operation, along with chemotherapy and radiotherapy again. Due to ongoing dyspnea, diagnostic workup was done to find that patient had severe aortic stenosis. Cardiothoracic surgeons agree with the need of valvular repair. However, due to the history of chest surgery and high mortality risk, the patient was referred to me for TAVI. Plus, BMI is just 18. It's very emaciated. Fragile female, diabetes, and CKD. Plus, medications and severe aortic stenosis. Plus, risk score is STS 9.7, Rogers Euro 49%, high-risk patients. Plus, X-ray shows radiation fibrosis, left pleural effusion or adhesion. ECG shows normal. Plus, chest CT shows radiation fibrosis and left lung apex, and bronchiectasis on right lung. Esophagogastrostomy status in the CD and left pleural effusion or adhesion. You can see the schematic graph of EVOLUT operation. There is a resection of esophageal cancer and anastomosed with esophagogastrostomy. Plus, echo TT shows concentric LVH, tricuspid aortic stenosis with moderate degree AL. Plus, Hyo-Soo has a mild mitral stenosis. In any way, AV pressure gradient is about 50 or more. Valve area is less than 0.8 square centimeters. Plus, we usually perform a TEE, real-time TEE, during TAVI procedure, but in this case, TEE is contraindicated in the previous surgery, EVOLUT operation. Plus, she had coronary lesions, so I performed PCI 2 days ago at CIRC and RCA. Now it's okay. Plus, she had a tortuous aorta. That is one point to consider selection of TAVI valve. Plus, she had also ovoid annulus and LVOT calcification shown here. That is another point to select TAVI valve type. Plus, coronary ostium, sinus height is good. 11 on the left, 18 on the right. Plus, once again, let's focus on calcium chunk from mitral valve apparatus to LVOT. You can see the calcification 3 millimeter below annulus at LCC side. 0.5 millimeter below annulus still there. 6 millimeter below the annulus still there. So there is continuous calcium from mitral valve apparatus to LVOT to LCC. That is a bad sign. Plus, another view to see the calcium chunk that continue from mitral valve to LVOT, LCC side. Plus, peripheral angio shows on the right side the minimal lumen diameter is 6.1. Thus, we expect we can advance the evolutized sheath, but it was not. Plus, on the right side, on the left side, even greater, 7.6. So we have to choose left side rather than right side. In any way, we are going to do inline sheath. plus peripheral angiogram shows both sides look okay, but actually it was not. Sometimes we overestimate the condition of iliofemoral artery. Plus, list of measurement of dimensions, perimeter around 70 millimeters, area around 400 square millimeters. Plus, when we select Sapien 3, 23 millimeter valve would be appropriate with 1 cc overfill, leading to 10% oversizing. Plus, when we choose EVOLUT 26 millimeter, oversizing index is about 16%. That is good. Plus, to summarize this case, she is absolutely indicated for TAVI because of high surgical risk with frailty. She also underwent 2 times of surgery radiotherapy on the chest. Choice of TAVI valve, I consider ovoid-shaped annulus, calcium from mitral valve to LVOT. I'd like to use EVOLUT. Also, tortuous aorta is another considering point. Oversizing index of EVOLUT 26 is 16%. I like it. And I'd like to show you the angiogram that we have done until now. Angio show punctured right side on the guidance of fluoroscopy, plus, and performed aortography. The best angle is LAO 10, caudal 10. We can see the continuous calcification from mitral valve apparatus up to the annulus. In CT, that is LCC side LVOT. That is a kind of problem in terms of safety and leakage. Plus, so I tried to advance the sheaths, but it was impossible. Thus, I used a 16 French dilator, hapless, because it just passed. Plus, then I tried to, once again, the advance sheaths. It is not. You can see the movement of calcification, focal calcification. The low limit of diameter for sheaths in EVOLUT system is 6 millimeter. Aortofemoral CT shows minimal diameter is 6.1 millimeter. Thus, we expect it is possible to advance the sheaths, but not.
But I thought
Thus, we switch to the inline sheath system. In any way, plus we use temporarily 16 French sheaths, and plus then advance wire through the stenosed aortic valve. Plus advanced and plus catheter, plus change to round shape wire, plus insert pictal catheter into left ventricle. Plus, then we check the status prepared EVOLUT. And you can see the pressure profile on the smaller screen. The peak pressure of LV is about 190, while aorta is 140, about 50 total difference at peak level. Huge widening of pulse pressure of aorta, suggesting moderate degree AR. Okay, from now on, we'd like to deploy the EVOLUT, so please discuss while we are doing our job.
그쪽 채우세요.
You have emphasized the presence of calcification around aortic annulus. So do you think this patient has a high risk of AV block after TAVI?
Alveolar calcification on the left side is not a predictor of complete AV block. On the septal side is important.
Dr. Kim, so you choose the EVOLUT TAVI device, and so do you have any preference between the S3 and EVOLUT R for particular these cases?
In this case, I already shown that for the safety, I prefer the EVOLUT in this case. Tortuous aorta and ovoid annulus, calcification on LVOT. If LOTUS is available, I surely chose LOTUS because it guarantees the safety and efficacy to minimize the leakage even in the presence of LVOT calcification. Of course, we expect the certain degree of leakage with EVOLUT in this case, but in our experience, even though we implant SAPIEN 3, in such a case, we cannot abolish the minimal leakage. Thus, for the safety of the patients, I chose EVOLUT in this case with optimal oversize index. No resistance in inline sheath advancement.
You know, many cases in which you cannot cross with the sheath, you can cross easily with the valve, just directly. The profile is somewhat a little bit smaller and a little bit smoother.
펴야지. LAO. There's some resistance in the ascending aorta. Cautiously. I prefer the image including both tip of advancing catheter as well as wire in the left ventricle. Okay, I advance. Please keep the wire. Subtle resistance. Test it.
Test it.
Okay. We can see the head morphology of distal end of delivery system. That means the alignment is very good. Okay. 자, 그대로 되겠네요. Okay. Yeah. I use two arms, right arm handling wire and left arm handling sheath. Okay. Test it.
Test it.
Okay. Start to deploy. Until now, the pressure is good, and we unsheath the flare capsule until the end of valve frame. Okay. Start. Deploy. There is some premature beat due to manipulation of stiff wire in the ventricle. So I'd like to do pacing at 100 to stabilize movement of heart. Not well captured,
TVC가 정말 생겼는데.
not helpful.
예. 레디에이션이 많이 생겼.
Okay, stop the pacing. Okay, without pacing, we are going to do. Okay,
갑니다.
deploy,
deploy.
stop.
Stop. 이렇게 괜찮습니다.
I think most important is tempo between 1/3 and 2/3. So in such kind of aortic valvular calcification that not severe, fixation is very poor, so easily deep down during the 2/3. Deploy. 천천히. Deploy. Test it.
혈압도를 좀 이야기하세요.
Okay. It's very high implantation.
It's very
Deploy.
good.
deploy,
Deploy. Deploy.
deploy,
Stop.
stop. 혈압하겠습니다.
So I'd like to do pause at the end of 1/3 deployment. Testing. Still now it is okay. BP is okay. You don't worry about. We don't worry. Hurry up. We don't need hurry up. So deploy.
deploy, 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 deploy,
Stop.
stop.
Testing.
But
It's very high implantation. Blood pressure start to decline. But it's okay still. Deploy.
deploy, deploy,
it's very nice.
deploy,
Deploy.
deploy,
Deploy.
deploy,
Deploy.
deploy,
Okay. Fixed.
Deploy.
Deploy. Deploy.
deploy,
Deploy.
deploy,
Deploy. Deploy.
deploy.
Stop.
네,
Test it. It's very high implantation.
Well,
very, very
this
high.
This is a little bit too high,
Very shallow.
definitely.
I try to a little bit push,
Yeah.
relieve of the tension.
Okay, you are retrieving it now.
No. Just retry again. The adjustment of position. Like kind of in LOTUS and layover process, just push the whole system forward to make the alignment, to make the position a little bit lower. Once again, that's 한번 해볼게요. Okay. On left side, and on the screen left side is about 1 or 2 millimeter ventricular. I totally agree. There's nothing to recapture the valve system. But in my experience, such kind of depth is really optimal when the bundle branch block is existing. Of course, in this case, it is not indicated. And usually, we see a huge amount of regurgitation until release process because the upper side captured. Thus, valve is not well functioned. Thus, we always see such kind of regurgitation. It does not mean it is infrascutal leakage. The depth is okay, but there is a possibility of upward movement at the final stage of balloon valve release. That is our concern. Such kind of regurgitation is nothing. No infrascutal leakage. Okay, recapture best angle. So we are going to recapture to make the ideal depth of the ventricle. Okay, recapture start.
맞습니다.
A little bit more.
네, 거의 다 됐어요. 빠져나왔어요.
Okay.
네,
Okay. Readvance. Blood pressure is okay. A little bit low.
It's okay.
Okay. Deploy again.
deploy, deploy,
Now a little bit lower position. Stop.
네, 팁입니다.
Test. This is good. Blood pressure is okay. A little bit low. Okay.
팁까지.
Deploy.
deploy, 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 deploy,
Deploy.
deploy.
Test. A little bit deeper than previous trial. A little bit pause. Deploy.
deploy, deploy, deploy,
That's nice.
Stop.
stop.
That's nice.
Test it. A little bit deep, but this is the level that you want. Deploy.
deploy, deploy, deploy.
아이고. Pop. Okay.
다시 리출하고.
Retrieve.
네.
It's not so
Can I give you another
Fixation.
small advice?
because
Dr.
annulus
Kim?
calcification is not severe in this case. Okay, we previously tried to pacing 100, not rapid pacing, but 100 rate did not well capture the ventricle. Thus, we cannot maintain the regular rhythm, a little bit low pressure. Thus, we cancel the pacing. We can do pacing a little bit higher rate, 120, to capture all the ventricle. Okay, blood pressure returns, then I tried the third deployment. How is the time? Do we have to wait for 15 minutes? Test it.
Test.
A little bit deeper than previous one. Third trial.
That's okay.
건가요?
Don't be greedy.
deploy, deploy,
deploy.
deploy,
이걸 조금 이쪽으로. 오케이.
deploy. 좀 올라가시고.
오케이.
deploy.
Stop.
Stop.
자, 120 pacing.
페이싱. 120.
120 pacing. Okay, well captured.
스테이블합니다.
Deploy.
deploy, deploy, deploy,
That's okay. The blood pressure is fine.
deploy, deploy,
Stop.
stop.
Test.
Test.
Okay. A little bit deep, but okay.
No, it's okay.
Deploy.
deploy, 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 deploy,
천천히.
No, that's okay.
Stop.
deploy, stop.
It will be fine. Now
Test
just
it.
be careful
Test
that
it.
you don't jump. Open, open, open.
Okay, 천천히 deploy.
deploy, deploy,
Deploy.
죄송합니다. deploy, deploy,
When you stop pacing, take care that it doesn't
Stop
jump
pacing.
because sometimes it's
pacing.
doing extra
Deploy.
systole.
deploy, deploy, deploy.
Stop.
열렸습니다.
That's nice.
Test. Test. Rhythm is okay. No AV block. Depth is good, about 4 or 5 millimeter ventricular. We can show you the other angle, okay,
LAO.
a little bit LAO with tangential.
LAO. LAO.
보고서 하라니까, 자네가. 오케이, tangential.
네.
오케이, 자, 쓰네. Shoot. It's
No, it will
good.
be okay. It will be okay.
It's very high still.
Yeah, this is going to be okay.
아래요.
Just don't stop to push the valve. Don't let it go up.
아래로 좀 적게 하고. Calm down. More. Tangential? No, not yet. AP. Tangential? Okay. Let's check the depth.
It is okay. Just
It's ideal.
just pull the wire a little bit because the wire is pushing
I
you.
already pulled the wire.
Okay.
Okay, can we release the valve with release of tension a little bit, push the system to prevent pop?
Yeah. But
off
give a
during
nice
the-
push when you're releasing it. Okay?
Okay, a little bit different angle. More. Tangential. Okay, slow release.
Deploy. 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 Deploy.
당기지 말고.
네. Deploy.
당기지 말고.
Push.
슈스를 어드밴스 해야 되겠네요. 오케이.
Deploy. 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 Deploy.
오케이, 테스트.
Test.
It's very, very high. Okay. Going to retrieve.
Okay.
거의 잡았습니다.
자, Wire stay.
네.
Okay, capture.
캡처했습니다. 잡아주세요. 네.
Okay.
시스 준비하시고.
Wire stay.
나왔습니다.
Wire stay.
네. 많이 잡고 있습니다.
Can you go back to the original angle?
베스트 앵글로 와주세요.
Looks better.
I know.
잡았습니다.
됐어. 저 위에 보면 돼. Then I withdraw the pigtail. It's very cautious to retrieve the pigtail pinched around. Okay.
Dr. Kim,
Yeah. Check. Yes.
do us a favor. Unlike the previous case with the Edwards, when you do the injection, do it without the stiff wire in the ventricle. It's interfering the valve function. It's stiff.
Okay. Once just check the root arterography with stiff wire in situ. Okay, 준비.
네, 준비했습니다.
It's good. Better than I expected. Then change pigtail. I'd like to change pigtail to LB and check the hemodynamics because we can't see TE in this case. Thus, I'd like to assess the amount of leakage through angio and hemodynamic measurement, pulse pressure, and AR
많이
index.
잡습니다.
이거 빼야 되나? 잠깐만.
Yeah, the position is good. I would do a post-dilatation here now. Well, what do the panel think? Should he do a post-dilatation? I think yes. Anybody else?
Dr. Zhang, do you have any additional burden?
Post-deal?
Yeah.
Yes.
notation
We
angio
already
and then measurement of left
15%,
ventricle pressure.
15% oversizing.
잡았습니다.
And there is no valve frame distortion on the expansion. So pressure profiles is uploaded, no pressure gradient, still wide pulse pressure. We are going to calculate AL index. The AL index was about 14 with moderate degree AL. Aortic diastolic pressure.
diastolic pressure
바꿔야지.
Aortic diastolic pressure.
(50) 누구야 지금 하는 사람이? 이지영 씨 아닌가? 전혀. 다이스톨릭 프레셔 50. Okay, while we are waiting for the, then once again, AR index is 27. Okay, acceptable. This is the autography with the stiff wire institute. We can see the regurgitation. That's the impact of stiff wire plus. Then we change to pigtail, a little bit decreased. Next. After removal of pigtail, still there is certain degree of leakage. To see the source of paravalvular leakage, we performed transthoracic echo. TTE, please.
에코 한번 보여주세요. 네.
Okay, this is a longitudinal section. We can see the valve frame plus. We cannot see a significant amount of leakage at this view. We can see the coronary flow upside plus cross-section image. Valve frame expands nearly round shape plus. We identified the pinpoint regurgitation at 2 o'clock. That corresponds to LCC. Because calcification is continuously connected from LCC, LVOT, and mitral valvular apparatus. A little bit lower level, next. We can see echo dense line at 4 o'clock. That is calcium between mitral valvular apparatus, LVOT, LCC. Thus, I think it is not helpful to do adjunctive overinflation. Angel, please. As you can see, we cannot see any underexpanded valve frame. Oversizing index already was about 16%. Okay, now we are going to do angiogram once again to expect further reduction of paravalvular leakage due to continuing expansile force of EVOLUT. Okay, 신의 준비. Still there, 800 PSI? Okay. The slide, please. To do or not to do. This is summary of our case. Very high-risk patients with frailty, breast cancer, esophageal cancer, 2 times radiation therapy on chest. As a score high. For the safety, I chose EVOLUT 26 millimeter. To optimize the ventricular depth, we tried 3 times. Finally, acceptable is ideal depth. Ovoid annulus, no problem. Calcium was problem, as we expect. As you can see, mitral valve calcium continues toward LCC LVOT. Then we don't see any underexpanded valve frame. Furthermore, we got LBBB, as shown here. Thus, there are 2 reasons that I don't do adjunct ballooning. The first one is LBBB may progress toward complete AV block. The second, paravalvular leakage due to LVOT calcification could not be improved by adjunctive balloon because we already implanted 16% oversized valve with no residual underexpansion. Okay, final angio. Final service.
Now it looks nice.
Okay, Dr. Kim,
Thank you.
with the final aortogram, I think we have to go now. So thank you for your wonderful contribution.
Thank you.
And congratulations on your case.